Hello, my name is Kelly Cascario, and I am doing my presentation on melanoma research. My grandmother on my mom's side died of melanoma when I was in the 6th grade. I still remember it like it was yesterday, so this topic is very close to home to me, and I want to learn more about the current research that is going on with it. So I want to start off by just giving a brief overview of what melanoma is. Make this bigger so you guys can see it better. Melanoma is a type of skin cancer that can start in the skin or mucous membranes. It is the rarest type of skin cancer, but the most aggressive with the poorest prognosis, and the occurrence of melanoma is on the rise. Risk factors for melanoma include a family history of malignant melanoma, more than 50 nevi, which are moles, fair skin, a history of serious childhood sunburns, and previous malignant melanoma. Signs of melanoma include moles that have changed in shape, size, and appearance, with irregular borders, asymmetry, color changes, satellite moles, and hair coming from the mole. As you can see on this picture here, there are some changes in the moles that you might see. Diagnosis is based off of biopsy and pathologic evaluation. These evaluations include Breslow's thickness, ulceration status, mitotic rate, plaque level, peripheral and deep margin status, microsatellite status, and histologic subtype. Treatment is dependent on the staging and can include surgery, systemic therapies, and radiation. So one of the researchers I looked into was research on the p53 gene. The p53 gene is known as the guardian of the genome, in that it plays a critical role in determining the fate of a cell. p53 is responsible for promoting an arrest of the cell cycle and then causing DNA repair. If it cannot be repaired, then it will proceed with apoptosis, which is the cell suicide. The outcome of p53 activation, life or death, is primarily due to its role in transcriptional regulation of numerous genes involved in these responses. Many types of cancer proliferate due to a mutation in the p53 gene. However, inactivation of p53 in melanoma is uncommon, and a wild type of p53 is frequently expressed at high levels. Recent studies have shown that not only is mRNA expression of p53 target genes aberrant in melanoma, but that p53 has lost the ability to regulate its target genes, particularly those involved in cell cycle control and apoptosis. In fact, the mRNA expression of these genes resembles that in melanocytes in which p53 has been knocked down by shRNA. Due to these changes with p53, melanoma cells can grow and proliferate, and they fail to respond to stimuli like chemotherapy that are meant to stimulate their apoptotic response. It is now believed that the p53 pathway promotes proliferation and progression in melanoma rather than acts as a tumor suppression. The next research that I looked into was the increased occurrence of melanoma. Melanoma can be caused by both natural and artificial sunlight. People used to think that they could get a tan by going to a tanning salon and not have to worry about the risk of getting skin cancer. It is now becoming more evident that tanning beds can also cause skin cancer. A news article was released in Britain that stated that every day more than 2 people under the age of 35 are being diagnosed with melanoma. The news article also stated that since 1970, the rates of melanoma diagnosis has tripled for people between the ages of 15 and 34. The number of cases of melanoma have increased from 1.8 cases of melanoma per 100,000 people to 5.9 cases per 100,000 people. From 2007 to 2008 alone, the number of cases rose 8.5%. Due to this rise in rates of melanoma, England and Wales enacted the Sunbed Acts of 2010, which made it illegal for people under the age of 18 to use a sunbed on commercial property, and businesses that do not follow the rule face fines of up to 2,000 lira. The next research I did was on early detection. Researchers in the UK have been given 75,000 lira by the charity Hope Against Cancer to help them develop a tool that will improve the early detection of cancer. It is being developed by a team of people from the Montfort University in Leicester. It will use a technology that is similar to infrared light called terahertz energy to take images of skin layers below the surface to assist in diagnosis and treatment. They are hoping that this tool will also be able to provide information about the precise area and size of the tumor to help aid in decisions regarding resection. Jeff Smith, who is leading the project with Kusini Secker, said, "Early recognition means that malignant melanomas can be removed surgically, improving patient outcomes." Another type of detection that I looked into is canine detection. Canines are used in a variety of occupational jobs. They are well known for their sense of smell, giving them the ability to detect bombs, search for drugs and paraphernalia, to help locate missing persons, and so much more. In 1984, a patient reported that their dog was persistently exploring the same spot on his leg, and it turned out to be a melanoma. There were 2 dogs used in this trial. One was a Schnauzer that had previously worked as a police dog, and one was a golden retriever that has certification as a master hunter. The dogs were sent through numerous trainings and testing prior to the start of the study. It is believed that the melanoma cells release volatile chemicals that create chemical markers in the blood and urine, and the canines are able to detect these chemical markers through their olfactory senses. The present results provide some evidence that there are volatile cues released from melanoma tissues that allow lesion localization by the canine olfactory system. Our work did not address whether the punitive cues might allow melanoma to be distinguished from the 2 other types of skin cancer. Thus, our working hypothesis is that there is, for the dog, an odor of melanoma that is recognizable as a different form from normal skin. Further research needs to be done on the chemicals released by melanoma cells, the limit of the canine olfactory system, and what other uses canines might be able to predict. Research into prevention. Prevention of melanoma can be accomplished by limiting exposure to sunlight, using sunblock when in the sun, and monitoring any moles and having them evaluated by a doctor and dermatologist. While most people have heard of these things, a newer concept not widely known is that NSAIDs may play a role in helping to prevent melanoma. Researchers in Denmark evaluated the effect that NSAIDs have in preventing malignant melanoma, basal cell carcinoma, and squamous cell carcinoma. The researchers analyzed medical records for the past 18 years and focused on patients that were diagnosed with skin cancer and reviewed their prescriptions. The risk of developing squamous cell carcinoma fell by 15% in people who filled more than 2 prescriptions for NSAIDs, and the risk of developing malignant melanoma fell by 13%, especially when taken for 7 or more years or taken at high intensity, compared with patients who filled 2 or fewer prescriptions. There did not seem to be an effect on patients with basal cell carcinoma. Next, I looked at the impact of genetic testing. Of all melanomas, 5 to 10% have a familiar clustering, and 20 to 40% of these are associated with a pathogenic mutation in the CDKN2A-P16, or simply P16 gene, a tumor suppressor that regulates cell cycle and senescence. Due to genetic links with melanoma, researchers did a study looking into psychological outcomes, perceived costs, and the benefits of genetic testing, reporting, and counseling. Results showed that people were found to have a mutated P16 gene and who were counseled with the information were at little risk of both short and long-term psychological adverse effects. Researchers also found that there were perceived emotional, behavioral, and informational benefits for both carriers and non-carriers alike. It is important to remember that even with a mutated P16 gene, people can still prevent the disease by avoiding natural and artificial sunlight. Next, I looked at treatment with different medications. The first medication is treatment with vemurafenib. Vemurafenib is the first molecularly targeted therapy to be licensed in the US and Europe for treatment of advanced melanoma. The mechanism of action is the selective inhibition of the mutated BRAF V600E kinase. By inhibiting the BRAF V600E kinase, vemurafenib causes a downregulation in the genes involved in cellular differentiation, proliferation, and survival of mutated genes. It has so far been shown to be the most effective drug of its type. In clinical trials, it showed an overall response rate of 48% and a 12-month overall survival rate of 55%. The most common adverse effects that were associated with it include cutaneous lesions, whether benign or malignant, arthralgia, and fatigue. The lesions that did develop were treatable and were able to be surgically removed with no further effects noted. It is now in clinical trials to be used in combination with other medications to treat metastatic melanoma and other types of cancer. The next was the treatment with trametinib. It's the first class in nitrogen-activated extracellular signal-regulated kinase inhibitors approved by the FDA for the treatment of patients with unresectable or metastatic melanoma with BRAF V600E or V600K gene mutations, as detected by an FDA-approved genetic test. Trametinib is a highly selective allosteric inhibitor of MEK1 and MEK2 enzyme activity and activation, which cause decreased cellular proliferation, cell cycle arrest, and apoptosis in melanoma patients. The clinical trials have showed a high level of efficacy with a progression-free survival time of 4.8 months and an overall survival rate of 81% at 6 months. Clinical trials showed that it is relatively safe. Common adverse effects include rash, diarrhea, peripheral edema, fatigue, and dermatitis acneiform. Just as with vemurafenib, it is going through clinical trials to determine its efficacy and safety when used in combination with other drugs to treat metastatic melanoma. The last drug that I researched was the nivolumab. It is a fully human monoclonal antibody against programmed death receptor 1, a negative regulatory checkpoint molecule with a role in immunosuppression. The clinical trials have found that after treatment with this, the number of CD4 and CD8 T cells that express the PD-1 receptor was reduced, allowing anti-tumor T cells to respond and destroy the tumor cells. Potential clinical anti-tumor efficacy was shown in melanoma patients that used nivolumab. Patients who received it every 2 weeks for a total of 96 weeks showed an objective response of 30.8% and 6.5% had stable disease for 6 months. Adverse events were noted in 30 of the 35 patients, with only 16 considered to be drug-related. Adverse events include decreased free thiodothyronine, decreased free thyroxine, and increased alkaline phosphatase, skin disorders, gastrointestinal events, and endocrinopathies. These are a list of the references that I used, and I hope that they are able to find further treatment and cures for melanoma, and I hope that my presentation was informational to you.